Session will deal with the venous drainage of the lower limb. So this is very important because not only for first year, not only for theory exam, but also for practical purpose. If you see in the final year examination in surgery, so one of the most important clinical case presentation is the varicose veins and deep vein thrombosis. So factors which help in venous drainage: contraction of the calf muscles, transmitted pulsations from adjacent arteries, the presence of valves in the perforating veins. This will allow only unidirectional flow. That means the blood will flow from superficial veins to deep veins only. So presence of valves in the deep veins. This will allow the blood to flow like columns against the gravity. And negative intrathoracic pressure, which is vis a tergo, which is caused by contraction of heart and suction action of the diaphragm. So this vis a tergo is sufficient enough in recumbent position for the venous drainage. So superficial veins are great stiffness vein and short stiffness vein. Deep veins are anterior and posterior tibial veins. They lie like vena comitatus. They are not single veins. They appear as vena comitatus accompanying the artery. The peroneal vein, popliteal vein, and femoral vein. That means below the knee joint, they are like vena comitatus, and above the joint, they are like single veins, except the peroneal vein. So perforator veins. There is one lateral ankle perforator, three medial ankle perforators, one below knee perforator, and one mid thigh perforator. So deep veins are medial plantar vein, lateral plantar vein, dorsalis pedis vein, anterior tibial veins, posterior tibial veins, peroneal vein, popliteal vein, and femoral vein. And here you can observe this is the great saphenous vein and this is the short saphenous vein. You can see this is the dorsal venous arch, lateral marginal vein, the medial marginal vein. You can see these are the three medial ankle perforators. This is the lateral ankle perforator. This is the Boyd's perforator or below knee perforator, and this is the Hunter's perforator or mid thigh perforator. So superficial veins, the great saphenous vein and the short saphenous vein. So great saphenous vein is the longest vein and it is the preaxial vein. So it begins as a continuation of the medial end of dorsal venous arch and it is also supplemented by medial marginal vein. So it lies 2.5 centimeters in front of medial malleolus. Then it crosses the medial surface of lower one third of tibia, ascends behind medial border of tibia, then ascends posteromedial to the knee joint, a hand's breadth behind the patella, then ascends along medial side of thigh, reaches saphenous opening 3 centimeters below and lateral to the pubic tubercle, pierces cribriform fascia, drains into femoral vein. You can see here, this is the dorsal venous arch. So continuation of the medial end of dorsal venous arch, supplemented by the medial marginal vein. So crosses the lower one third of uh, the medial surface of the tibia. So then ascends behind the medial border of tibia, then ascends in relation to posteromedial aspect of the knee joint, a hand's breadth behind the patella, then ascends on the medial aspect of thigh, pierces the saphenous opening and drains into the femoral vein. Here you can see this is the posterior arch vein which is formed by the venous arcades joining the three medial ankle perforators. Here you can see the anterior leg vein. Here you can see the adductor canal perforator and the below knee perforator. Here you can see this is the anterior lateral vein and this is the posteromedial vein. So these are the tributaries. These are all the tributaries of the great saphenous vein. Here you can see the superficial external pudendal vein, superficial epigastric vein, and superficial circumflex iliac vein. So structures which accompany the great saphenous vein are in the thigh. You can see few branches of medial femoral cutaneous nerve. At the knee, saphenous branch of the descending nuclear artery, and in the leg and foot, the saphenous nerve. Tributaries are the posterior arch vein, connecting three medial ankle perforators, then anterior leg vein, communicating vein with the small saphenous vein in the leg, the anterolateral vein, posteromedial vein, also called as accessory saphenous vein, superficial epigastric vein, superficial circumflex iliac vein, superficial external pudendal vein, and sometimes there might be a thoracoepigastric vein which connects the superficial epigastric vein with the lateral thoracic vein. Ultimately, it is connecting femoral vein with the axillary vein and deep external pudendal vein. So perforator, there is one lateral ankle perforator. So where short saphenous vein is connected with the peroneal vein, three medial ankle perforator which connects great saphenous vein with the posterior tibial vein. So the upper one lies at the junction of middle one third and the lower one third of tibia. The lower one is below and behind the medial malleolus, and the middle one is midway between the above two perforators. All above three are joined by series of arcades forming posterior arch vein. One below knee perforator which connects great saphenous vein with the posterior tibial vein. One mid thigh perforator, also called as mid hunter perforator, in the adductor canal. So it connects great stiffness vein with the femoral vein. So valves around 10 to 20 in number in the great stiffness vein. So saphenofemoral valve, it is junction with the femoral vein, most important valve. 80% people external iliac vein also has a valve which have additional protection for the SFJ valve. In 20% it is absent, so complete burden lies on the SFJ valve. Short stiffness vein has 7 to 13 valves. So it begins below and behind the lateral malleolus as a continuation of lateral end of dorsal venous arch and supplemented by lateral marginal vein. Ascends along lateral edge of tendocalcaneus. Sural nerve accompanies it on the lateral side. Ascends on the middle of the back of the leg. After piercing deep fascia, undergoes subfacial course between two heads of gastrocnemius. At middle of the popliteal fossa, dips deep to terminate in popliteal vein. And other modes of termination of short stiffness vein are: it joins with the great stiffness vein directly or through accessible stiffness vein, or bifurcates, in which one branch joins the great stiffness vein, other terminates in popliteal vein, or below knee itself it ends in great stiffness vein or deep veins. You can see this is a short stiffness vein terminating in the popliteal vein. Posterior femoral cutaneous nerve accompanies the short stiffness vein before becoming superficial. So here you can see the superficial vein draining into the soleal venous sinuses, and ultimately that is draining into the deep vein. So everywhere valves are present directing the blood from superficial veins to deep veins. Here you can see directly the perforator connecting the superficial vein with the deep vein. So applied aspects: varicose veins. Abnormal dilated tortuous veins are called as varicose veins. So incompetency of saphenofemoral valve and incompetency of valves of perforators and persistent rise in intra-abdominal pressure. So these are the causes of varicose veins. The treatment is removal of the great stiffness vein through stripping operation. So other complications are deep vein thrombosis, venous ulcers, and great stiffness vein is also used in coronary artery bypass grafting. You can see these are the varicosities of the great stiffness vein. So Trendelenburg test, this is used to identify the incompetent valves either in the saphenofemoral valve or the perforator valves. So you can see how it is performed. Patient will lie on the supine position. Patient leg is elevated to drain the venous blood. An elastic tourniquet is applied at saphenofemoral junction. Then the patient stands with tourniquet in place. If there is rapid filling within less than 30 seconds, then there is perforator valve incompetent. So if there is no filling, then the perforators are competent, and then the tourniquet is released. If the filling of the great stiffness vein occurs from above, that means saphenofemoral valve is incompetent. You can see these are the varicose veins before surgery and after surgery. So short stiffness vein varicosities before surgery. So you can see here again the varicosities in the medial aspect of the leg before surgery and after surgery. You can see here the stripping of the great stiffness vein being performed. So this is a venous ulcer. So deep vein thrombosis. So the common signs are like distinction of the surface veins, pain and tenderness, redness or change in coloration, swelling and warm feeling of legs, sudden fainting, sudden rapid pulse, coughing up of blood, pain in the foot and ankle, feeling lightheaded or dizzy, unexplained sudden shortness of breath, pain in one leg that increases when legs are pressed. So if you see, initially there will be pain and swelling, especially in the calf. The signs of pulmonary embolism like pleuritic chest pain, hemoptysis or shortness of breath when there is embolization. So sometimes leg appears cellulitic and very occasionally it may be white or cyanosed. So these conditions are called as phlegmatia alba dolens or phlegmatia cerulean dolens. So there might be mild pitting edema of the ankle, dilated surface veins, stiff cough and tenderness over the course of the deep veins. Homan sign, So pain in the calf when there is dorsiflexion of foot and at the same time there is squeezing of calf muscles. So you can observe here. So the calf muscles will be squeezed and there is dorsiflexion of the foot that results in pain in the calf. That is positive Homan's sign, which is indicative of deep vein thrombosis. So test for deep vein thrombosis with patient lying supine, and examiner squeezes the calf firmly and dorsiflexes the foot. The test is positive if deep seated pain is felt in the calf. You can see the deep vein thrombosis, how the skin appears in a DVT. Thank you.